And I would like to hand over to Malcolm Crick again, and he will lead us through this part of the session.
Thank you, Werner. Well, I hope you agree that we've had quite an interesting morning. I've certainly got some questions, and I hope there are plenty from the floor. So the rules are as before. Please move to the microphone when recognized by the floor. Move to the microphone, and please state your name and affiliation for the record, so that we can capture that for our records.
Thank you very much. Thank you, Malcolm. Thank you very much, the distinguished speakers. We learned a lot this morning. I have some comments to the
Mehdi, you're...
Yes, I'm Sohrabi from Iran, from Amir Kabir University of Technology. We heard about dose and dose rate effects. Of course, I'm not a radiobiologist, but when I did my PhD at Georgia Tech, I took minor in radiobiology with 19 credit hours. So we talked about dose and dose rate effects, but I do not see any discussion or any studies on fractionation effects at low doses. We all understand this in radiotherapy, but at low doses, nothing seems to have been done. And that is extremely important. And we know what happens when we do survival cares at low doses. So I like comment on that, because this fractionation, what we are doing is we are using Hiroshima and Nagasaki data, which is an unfractionated dose to the population, to radiation workers, which they have fractionated dose. So what we are having now, we have dose limit for radiation workers. And with this dose limit, a radiation worker in Australia, one in England, one in Iran, one in USA, they have different risks at the moment. So I'm proposing to apply risk limit, and I have formulation how to apply dose risk limit instead of dose limit for radiation workers. And then this will affect very much the risk factors that we will receive from epidemiological studies, for example, in works.
Yeah. Mehdi, the question,
yes.
Keep focused now, please.
So this is what I have. So based on this, I'm recommend, for example, we have some epidemiological studies which they only use external radiation. We have some, they use external radiation and internal doses, and none of them use whatever we are receiving, for example, like in USA, 6.2 millisievert per year, that in general, any radiation work we receive. Right. So these are my comments to you, and I'm available with my comments to make a change in ICRP, if I am invited. Thank you.
Thank you very much. I think if there's any reflection on that, it would come probably from Werner. Do you want to say something, Werner, particularly about the fractionation issue?
Well, maybe Simon could give some indication. I'm not a radiobiologist, so maybe he is more qualified to say something. We'll move
to Simon, or it wasn't radiosensitivity.
Okay. Well, I mean, I would agree that consideration of fractionated exposures is important and can be informative. I'm aware that there are some experiments going on in the sort of radiobiological area using multiple, or aiming to use multiple small fractions. I would agree, though, there's not really an awful lot of data out there on that particular kind of exposure scenario. But also, as you pointed out yourself, there are epidemiological studies where there is a kind of a intermittent exposure, one might describe it, in the radiation worker studies. So obviously, they're probably not exposed very much at weekends and so forth. So that is informative about that sort of exposure type.
Okay, thank you. This side, then you'll come back here.
Wes Balch, University of Florida, member of C2. I have two quick questions. The first one to Dr. Hendry. This is more clarification for C2. In your stem cell report on the skeletal tissues, the bone cancer stem cells and the leukemia stem cells, is there any new information on spatial locations? And I'll just quickly remind you what we do in ICRP is we average the dose across the whole marrow cavity. So implicitly, we're assuming the hematopoietic stem cells are everywhere. There's not a spatial gradient, and I think there's evidence that there is. And then we made a change in the 10 micron endosteum to a 50 micron endosteum. Really is a kind of a placeholder, knowing that the osteoprogenitor cells are further deep into the marrow. Is there any further evidence? We made a change in the last couple of years in ICRP to average the dose from 10 to 50, but is there any now more biological, histological evidence to support that?
Jolyon?
Yes, you're right. I don't think that we have anything new in the last few years.
Okay.
You're right that there is a distribution which is in the literature, but I don't think it has advanced any further.
Yeah, okay, very good.
From that.
In cases where you have short-range radiations from the bone surface of bone volumes, there's potentially a dose gradient, so assuming where the target cells are may change the estimate of the dose.
Yeah.
Yes.
So thank you for that. The second question, Dr. Asasa, the issue of, I know this is maybe very premature, but if and when we add cardiovascular disease to detriment, Committee 2 is going to need a target tissue.
Yeah.
What should we calculate those to, or is that just a premature question at this point?
Excuse me?
So the question is, for looking at cardiovascular disease, if evidence is brought to bear that this is an additional stochastic effect that should be included in ICRP's definition of detriment, those of us in Committee 2 that do, we have to calculate dose to a tissue that would be correlated, predictive. So is that the heart wall? Is that the kidneys? Is it whole body? Is it, at some point we need to know what dose is most correlative to cardiovascular disease if we're going to add that to the system. It may be a premature question. So.
No, but the mechanistic background also. Organ, you mean the organ dose?
Yeah, which organ should we calculate dose to correlate to?
Which organ? I think the organ dose for heart.
The heart wall?
Yeah.
Okay,
Yes.
okay. As opposed to, okay, very good. Thank you.
Okay, thank you. Come over here.
My name is Kimberly Applegate, and I'm a member of C3 and a pediatric radiologist. So my question is regarding children, and I think I want to ask Simon this question about some populations that may be more radiosensitive than others. And I really enjoyed the whole session, and particularly the discussion about certain populations that may be more radiosensitive. And you talked about some of them. One that you didn't talk about necessarily was certain phases in life when the breast may be more radiosensitive. And one of the things that we struggle with children is a kind of a lack of discussion when there may be more either endocrine stimulation or growth, cell growth. And those periods are the neonate with maternal stimulation, adolescence when there's breast growth, and then pregnancy in the breast. And so I wondered if you might talk to us about any knowledge you have in sharing with guidance for people practicing medicine and the increasing exposure to the breast.
Well, I can try a little bit. I won't give you a perfect answer. I mean, some of the information I showed did indicate, pregnancy factors being important as potential risk modifiers. So that is an area of interest and concern, perhaps. We know something from epidemiology about age dependency of risk, indicating that the young are generally at risk. I have to admit, I don't know myself particular studies addressing the sort of issues you're talking about, the more sort of real-life clinical situations you're faced with. But I think looking at looking at any interaction between an exposure and individual related factors, be it sort of growth related or whatever, is well worthwhile. There will be, I would expect, interaction between particular developmental phases within particular tissues and their sensitivity. I think I'm right in saying they're not particularly well characterized at the moment, and certainly hormonal stimulation effects do affect cancer risk generally, that is known, and obviously in the breast that's particularly obvious. So yeah, it's an important issue perhaps to identify or to gain a bit more information about before it can be applied, for sure.
Thank you.
Okay, thank you. Please.
Hi, I'm Frido Zölzer from the University of South Bohemia in the Czech Republic. I have a question about dose rate effects. Some years ago, in the first MELODY workshop in Stuttgart, a Japanese colleague spoke about dose rate effects for mutation induction in mice. I don't remember the name, but I found it quite interesting because he said that in different tissues, they found different dose rate effects. So maybe there is no such thing as a DDRF or the DDRF, but maybe as much as we have tissue weighting factors, we will have to have tissue weighting factors for dose rate effects. Is there anything known about this? Anything more than this one study from Japan?
Well, I'm not aware of additional studies, but in general, of course, if you look scientifically on this topic, you can have a lot of things to investigate and to learn, but in the end, for radiological protection, we shouldn't make it too complicated. So if such effects are there, in the end, I think we have to find a practical way to implement such knowledge into the radiological protection building.
Mm-hmm. I think that's a fair answer. Please.
Ranaji Chakraborty from a member of C1. I would like to go back to the radiosensitivity issue. Mm-hmm. In late 90s and early 2000s, when the animal experiment results were out for radiosensitivity differential, we did some modeling of effect of radiosensitivity differential to revision of risk calculations. In summary, the results were the genetic variant has to be conjointly responsible for cancer susceptibility as well as radiosensitivity. Second, the polymorphism should have high frequency. And third, the radiosensitivity differential as well as cancer predisposition has to be dramatically large. Mm-hmm. But unfortunately, the experimental results of measuring radiosensitivity that were available were rather poor. For example, we did some modeling of G2 assay work of David Scott. We did find bioinformatically presence of major gene. Then we looked for association. The results were at best mildly significant. Now, my question with respect to Dr. Matsura's study is you now seem to have a novel technique of not association, but real causative mutation responsible for the event. My question is there any genomic context restriction to do such genome editing? Can you guide us in that respect?
So you are asking genome editing? Yeah. It is possible to introduce single base pair gene editing, but in cell. But to tell the truth, it is not easy. So we developed a two-step strategy. This this method enabled efficient homologous recombination mediated genome editing, but it's
more specifically, my question is as follows. Say, for instance, by doing some in silico work, we say that on this DNA repair gene, this polymorphism might be influencing cancer predisposition and might be involved in radiosensitivity as well. Now, is there any context of that polymorphism that would restrict your genome editing technology?
Yeah, I can edit in any cell type.
That's good. Thank you.
Thank you.
Thank you very much. Ted Lazo from the Nuclear Energy Agency. To take a little bit step towards practicality, in talking about individual sensitivity, it seems as though there are two groups of the population that are fairly large and easy to identify, and we know that their radiosensitivity is somewhat heightened. That's women and children. And the question is, from a research standpoint, would you say that those differences in sensitivity are more due to biological sort of reasons, or are there behavior and environmental aspects that would account for part of that? And the rationale behind understanding that is, if it's biological, perhaps the populations could be focused on for optimization processes in an occupational setting or in an emergency setting, whereas if it's environmental or behavior choice, it's maybe less of a need to focus on optimizing for specific groups.
Good question. Simon?
I think it's pretty clear that there's some biological basis for the variation you see with age and with gender, and that's shown in breast cancer risk, for example, and well, to some extent, sort of supposition that the age, the sensitivity of children is to do with their sort of very well, not unusual. That's probably it's very common because we all go through it, but their very particular developmental stage and the sort of activities in their cell populations and so forth that Jolyon was referring to. There are tissues mature at different rates, and the brain, for example, develops all the time. You know, it doesn't stay still, and we don't stay still, and that's one of the messages I think coming from the stem cell work. So I think there's largely a biological basis, is my own view, but there will be environmental factors coming into play as well, and that might in particular be relevant for lung cancer, where smoking behaviour is obviously going to be a critical factor. And looking back to the UNSCEAR report on sensitivity of children, identified lung cancer as being one of the cancer sites which is not showing childhood sensitivity, and that may be related to the smoking behaviour of that population group.
Okay. Thank you. John?
Yes, thank you. Hello? Yes, hi. John Boyce, Maine Commission. Just wanted to make two comments. One about the sensitive periods in women's lives when they have an enhanced radiosensitivity to carcinogenesis. And there are, just to reinforce what Simon said, there are human studies of young girls who were monitored with spinal x-rays for scoliosis. And they're going through the growth hormone, the breast development stages, and the breasts are particularly sensitive during these ages for developing cancer from fractionated exposures. And the other example has been several studies now of women who are pregnant that receive radiotherapy, that there is an enhancement of the risk because of the hormonal milieu. So we do have human evidence that in addition to the age effects, that there's these special periods in women's lives which make them at a particularly high risk. On the other hand, too, when you're thinking about age, if you're past the menopausal ages, though, if there's any good news, then there's very low risk of radiation-induced breast cancer in older women. So there is that complexity, if you will, for the issues. The other thing I wanted to mention, too, about dose and differences in tissue by dose and dose rate effectiveness factors and fractionation. And there's clear evidence in animal studies that different tissues respond differently to different, to fractionation. There's also evidence in humans. In the studies we've done with tuberculosis patients having multiple chest fluoroscopy, there's clear evidence for breast cancer, an effect in the United States and Canadian studies. And both of us are consistent in not finding an effect for lung cancer. And one of the interpretations is that tissues vary with regard to their response to fractionated exposure. And that's another thing just in general, when you talk about this global DDREF, we're lumping all tumors together. And that's different biological responses. And so does that in fact make a difference when you're doing even the meta-analyses? That would be the question, when you have all the tumors together where there's different responses. For biology, perhaps it does make a difference. For protection, perhaps it doesn't.
Yeah. Thanks, John. I think that comment echoes the question we had earlier on, but Werner, do you want to just reflect on that?
Just a short comment. In fact, what we try to do within the task group is to have a look at all solid cancers together, I mean, for the epidemiological studies, but we will also try to look at various endpoints, colon cancer, stomach cancer, whatsoever, just to check whether there are differences. But probably in the end, yes, to keep it simple again, one has to, but that's not the task group who has to decide this. One has to combine everything and put it into one factor.
It's a tricky decision. Dr. Streffer, I'm sure you have some very interesting words of wisdom to...
Thank you very much, and especially for your expectation. Christian Streffer from Germany. I would like to make a remark to DDREF and a question to Dr. Osasa. First, a remark. I thank you very much to go into the history of DDREF, which is a very long history, as you explained it, very emotionless. And I want to stress this, emotionless. I had 26 years experience with Anskia, so I had the experience with a good deal of development of DDREF, and I never had a topic with so much emotion in Anskia. It was fantastic. And when we made the decision, we had values between 2 and 20. And when we made the decision to 2, it was a tremendous uproar. And one delegation left the room. I think this was the only case that this happened. And we needed a good deal of Austrian wine in the evening to bring people together again. But next day we were sitting again together. So that's just for history, perhaps quite interesting. Well, to Dr. Osasa, a question. As I understood this correctly, you said you don't see an effect on cardiovascular diseases in the low dose range, only in higher dose range. And this is more or less in agreement also with the Anskia report, where the conclusion was that there's no effect below 0.5 Sievert or Gray.
Great.
And my question now is, do you really think, or would you suggest to include a discussion of cardiovascular damage to include this into the detriment and to consider this as one factor for low dose and dose limits?
About low dose effects, actually the results from atomic bomb survivors are mostly based on high dose levels result. So, including the cancer results and as well as non-cancer results, in my opinion, the results at the low dose levels is quite uncertain from the atomic bomb survivors.
Thank you very much. I think this might be very important for the discussion in the future.
I think the key is to try to hypothesize the mechanism, right, Christian? I mean, that would be the issue. Does anyone want to comment on that? No. Exactly. Okay. Yes, please.
Yeah. I'm from the KIRAMS, the National Emergency Medical Center of Korea. So I have one question to Dr. Ozasa. Yeah. Yeah. You said that before using the ICD-10 definition, the death from heart failure might include some malignancy, right? Dr. Ozasa. Yeah. Yeah, you said that before using the definition of ICD-10, you said that the death of heart failure from ICD-10, before using the ICD-10 definition, the heart failure might include some malignancy, right?
Heart failure?
Yeah. Before
So,
using,
because when the patient died in uncertain situations in the house, so the physicians couldn't evaluate the patient's situation correctly. So he diagnosed the patient died of simply of heart failure. So that is the confusion.
So my question is there any special reason you mentioned the malignancy? Because it is true, because it is true, is there any possibility of underestimating of cancer by LSS study?
Yeah, I don't think so. I don't think such effects on the estimation of cancer risks.
You mean there is no special reason you mentioned malignancy?
No.